Mother's Grief by Margaret Cupit-Link, MD, MSCI. Tristan was a cherubic 2-year-old boy whom I had met only a handful of times during my first year as an attending physician. Twice when he was admitted to the hospital for induction chemotherapy, and once when he was admitted for febrile neutropenia. I knew that he had a long and painful road ahead of him. It was the only way to cure high-risk neuroblastoma. Tristan was typically sleeping during my visits, tucked under the arm of his simultaneously sleeping mother. The hair on his head was long gone, but thick eyelashes remained, fanning out over chubby cheeks. His eyelids were puffy from the intravenous fluids we pumped into him to protect his organs from chemotherapy. I never saw him without his pacifier, which he sucked on slowly and reflexively, the way only sleeping babies can. Although I tiptoed into his room without speaking and only lightly touched his abdomen when examining his G-tube site, a few times I woke him. He would briefly stop sucking on his pacifier, smile at me from behind it, and then close his eyes to resume sucking. It was impossible for me not to be reminded of my own son, who was also bald and plump-cheeked with an ever-present pacifier. On one occasion, the nurses alerted me that Tristan's mother was breaking the rules. She was co-sleeping. Rather than putting him down in his crib to sleep alone, she laid next to him in the bed, her arms wrapped around him. Not considered safe sleep, it was against hospital policy. I imagined my own son, contained in a hospital room, attached to an IV pole, vomiting from chemotherapy. I could feel the warmth of his skin against mine, the weight of his body on my chest, and as I looked back at Tristan's mother, I could only support her decision to hold her baby. The day it happened, I had just taken over the inpatient service again at the end of my first year as an attending. Tristan had just undergone consolidation with an autologous stem cell transplant. As I drove into work, my colleague called to give me handoff. She told me that Tristan had been transferred to the intensive care unit and was on vasopressors for septic shock. I pictured him in the ICU, his small and vulnerable body, the same size as my son's, being resuscitated. When a wave of nausea came over me, I reminded myself that I was not Tristan's mother. I was his doctor, and I had to remain calm to try to save him. I arrived to the ICU and saw Tristan lying in the bed awake, pulling on the respiratory and cardiac monitor leads that were stuck across his chest and fiddling with the new IV and arm board on his right wrist. I was relieved to see that he was alert and active, his lips turning into a smile behind his pacifier as I approached. I felt an urge to hold him and to kiss his bald head. Instead, I crossed the room quickly and approached his mother, who was asleep on the couch. When I touched her on the back and quietly said her name, she woke with a startle and sat up. Makeup from the day before was smeared around her eyes. I asked her how she was doing, and I could tell that she had no idea how ill her child was. Looking at him, I could not blame her. I gave her a basic definition of septic shock and explained that her baby was on strong antibiotics and many medications to keep his blood pressure from dropping too low. When she asked, "He'll still be okay, right?" I wanted to convey the seriousness of his condition without making her panic. "I hope so, but it will depend on how he does over the next few hours," I cautiously responded. She seemed disappointed by my answer, but remained calm. I held on to her hope. I needed it too. About an hour later, I was rounding with the residents when my pager interrupted. The critical care attending wanted to know if Tristan was a candidate for intubation and extracorporeal membrane oxygenation, ECMO. The vasopressors were no longer sufficient, and his respiratory status was worsening. I responded with a yes. His cancer was probably curable. I used a phrase that I often avoid when speaking to families. Do everything for him. And I rushed back to his bedside. His mother was still in his room, crying in the corner, while the team rapidly intubated her son. I noticed that she was grabbing something that was clipped to the front of her skirt. It was Tristan's pacifier, the same one that he had been sucking when I visited him just hours before. I touched her arm and asked if she would come with me to talk. She agreed. She didn't want to watch. Neither did I. I took her to a conference room, A cold room with a large rectangular table surrounded by comfortable office chairs. "Are you okay?" I asked her, immediately regretting my question as she stared blankly at me in response. I knew that she was not okay. Had I been in her shoes, I would not have been okay either. My memories of the events that followed remain vivid. Tristan's grandmother arrived, crying hysterically and asking for an explanation. I did my best to explain the diagnosis of shock and its potential causes. This is no one's fault. It is a complication of transplant. I tried to convince them, as well as myself. A chaplain joined us and offered some prayers. When they asked me the dreaded question, "Is he going to die?" I responded with honesty. He might, but there is still a chance he will be okay. Then we sat around the big table in silence and waited for what felt like hours, while his heart slowed down, while cardiopulmonary resuscitation was initiated, while the cardiothoracic surgeons prepared the room for initiation of extracorporeal membrane oxygenation. After what felt like hours, but it was really only minutes, I left the room to check on Tristan. Members of the code team were taking turns, heaving themselves over him and pounding on his chest, keeping his heart beating. The pharmacist stood in the hallway, drawing up medications and doling them out as they were requested. The surgeons cut him open at the bedside, blood streaking across the white hospital sheets and dripping onto the gray vinyl floor tiles. They attempted to thread the pieces of ECMO circuit into his blood vessels, failing repeatedly because his body was swollen and his vessels were clamped down. I found myself looking at his face, so puffy and pale that it no longer resembled him. I wondered if there was anything left of him in that body. Had his soul already escaped? The hallway began to quiet. The slowing beep of his heart rate disappeared from the monitor. I heard a physician mutter a curse word. Several of the team members who were taking turns doing chest compressions looked at me. "Should we call it?" the team leader asked, looking in my direction. I tried to talk and could not. I knew the correct answer was yes. The destruction of his body, with pumping and cutting, had been futile. He was not going to come back. I shook my head no, involuntarily, driven more by emotions than by logic. I could not give up on him, this baby boy who had been happily sucking his pacifier just hours before. I could not let go of hope. My mentor, who also cared for Tristan, had been there for a while, and she jumped in to help me. "I think we have to stop now," she said, and I let out a loud sob. Tears streamed down my face, and I finally let myself break down right there in the hallway while the code team disseminated and the nurses began to clean up Tristan's body. A few minutes later, my mentor and I returned to the cold conference room. As we opened the door, Tristan's mother abruptly stood up from her chair and looked at us, asking the question with her expression. I simply shook my head and said, "I'm so sorry." His grandmother let out a loud moan, sounding like a wounded animal. Tristan's mother just nodded her head solemnly and asked, "Can I see my baby now?" When she rounded the corner at the end of the hallway and reached his room, she crawled into bed with him and held his dead body, rocking back and forth and crying, my baby," with silent tears streaming down her face. 7 hours later, I had the awful responsibility of telling her that she should leave and allow his body to be wheeled down to the morgue. It has been 6 months since Tristan died, the hardest death I have dealt with in my career. I'm surprised that I have struggled so much with his death, although I hardly knew him. I keep reliving the events, putting myself in his mother's shoes. At first, I believed that I had no right to grieve in this way, and that it was his mother's grief, not mine. I reminded myself that I was not Tristan's mother. I did not give birth to him or name him. I did not have to learn from an emergency department doctor that my 1-year-old son had a giant tumor in his abdomen. And I was certainly not the one who held him in the bed every time he had to stay overnight in the hospital. Now, after some time has passed, I know that my grief is mine, and that I am allowed to feel it. I may not be his mother, but I am a mother. I grew a baby boy inside of me for 9 months and loved him the moment I felt his little kicks in my belly. I fed him at my breast and watched him fall asleep in my arms month after month. I celebrated the first time he rolled over and shrieked with delight the first time he crawled across the room. I had hoped for and dreamt about his future. I know what it is to love the way only a parent can love, so I can imagine how it feels to lose the way only a parent can lose. I once hoped that by feeling Tristan's mother's grief, I could take some of it away from her, that I could share her burdens so that she could keep breathing. And now I know that this is not how grief works. If grief is anything like love, it cannot run out. It will keep pouring into anyone who is open to receiving it. I have started my second year of work as a fully trained pediatric oncologist, and I'm still learning how to cope with Tristan's death. I know there will be other deaths in the future that cause me similar pain because I am now and forevermore a mother, and I will always empathize with other mothers. Tonight, I hold my baby boy in my arms, rocking him back and forth as my tears drip onto his soft, plump arms. I put his beloved pacifier into his mouth, stare into his eyes, and tell him how much I love him over and over again until he has drifted into a deep sleep. I look down at his thick eyelashes fanning out over chubby cheeks. I am aware that each moment with him is precious.
Welcome back to JCO's Cancer Stories, The Art of Oncology. This ASCO podcast features intimate narratives and perspectives from authors exploring their experiences in oncology. I'm your host, Mikkael Sekeres. I'm Professor of Medicine and Chief of the Division of Hematology at the Sylvester Comprehensive Cancer Center, University of Miami. What a treat it is today to have joining us our third place narrative medicine contest winner, Margaret Cupit-Link, an assistant professor of pediatric hematology oncology at Cardinal Glennon Children's Hospital of St. Louis University, to discuss her Journal of Clinical Oncology article, Mother's Grief. Both Maggie and I have agreed to call each other by first names. Maggie, thank you for contributing to the Journal of Clinical Oncology and for joining us to discuss your winning article.
Thank you so much for having me and for choosing my article. It's an honor to get to speak to this group. I know a lot of our listeners have a lot in common with us in our profession, so I'm excited to be here.
We're excited to have you. You are such a terrific writer. Tell us about yourself. Where are you from? And walk us through who you are at this stage of your career.
I grew up in a small town in Mississippi called Brookhaven, and I ended up attending college in Memphis, Tennessee, which is important to note because I was a pre-med student when I got diagnosed with childhood cancer, Ewing sarcoma at the age of 19. And so that really shaped my career goals. And I was treated at St. Jude Children's Research Hospital, which is very formative as well, given that I was surrounded by childhood cancer patients. I ended up doing my medical school at the Mayo Clinic Medical School in Minnesota, which was very cold for me, but a wonderful experience. And then went to St. Louis, to WashU, St. Louis Children's for my residency, and then back to Memphis for my fellowship at St. Jude. But now I'm back in St. Louis at the other hospital, Cardinal Glennon, which is affiliated with St. Louis University. And my husband's originally from St. Louis, so it was always a dream of his to be back here. And once I ended up here, I really have loved St. Louis as well. So this is home for us and our two babies who are ages 1 and 2. And they are 1 year and 1 day apart, exactly.
Oh, my word. Well, you are definitely in the thick of it, aren't you?
It's a very busy, chaotic life, but I'm very grateful. And so that makes it wonderful.
That sounds fantastic. Well, I'm calling in from Miami today, so believe me, the thought of being in Rochester, Minnesota is not very appealing in mid-February.
I believe that. I'm glad I'm not there right now.
Gee, I didn't know about your history of having cancer yourself. What was it like to return for fellowship at the place where you yourself were treated?
That was an incredible experience for me. It was very emotional as well. I remember the first day of fellowship getting a tour and crying throughout the tour. More tears of joy, but it was really surreal. It was really special. And I got to learn from some of the doctors who treated me, which made it really special as well. I'm really glad I got to train there, and to be at a place with such a large volume of pediatric oncology patients was a really great learning experience.
I wonder, infrastructures, buildings change over a few years, particularly in medical centers. Was there ever a moment when you were talking to a patient who was sitting in the same chair where you were sitting when you were a patient? And was that something that you were open to sharing with people?
All the time, on all accounts, yes. The infrastructure has changed and continues to grow significantly, but the clinic hadn't changed at that time. I think it will in the next couple of years. But the solid tumor clinic where I was treated was exactly the same. And there were many times where I took care of sarcoma patients and Ewing sarcoma patients who were teenagers, as I had been, in the very same rooms, and times where I learned from my own oncologist as he was teaching me and training me. So it made it really special. It made empathy a big part of my experience. And I think it is for all of our experiences in oncology in particular. But I think that empathy has always been a huge part of my job and something that comes to me naturally, which is a gift. But as is sort of alluded to in my piece that we're discussing today, can be difficult at times. Empathy can also sometimes be a curse when it's hard to turn off. And that's been something as a mother now that I've really had to learn to cope with, is like figuring out when my empathy might not serve me in moments and might not serve the patient in moments, and when it is an asset and a gift.
Empathy at the deepest possible level, having walked the same path your patients have walked as well. Really a remarkable story, Maggie.
I'm very blessed to get to be alive and well, but especially to get to have a job that's so meaningful to me and hopefully can share my experience in a way that helps my patient.
And you share it through writing as well. When did you start writing narrative pieces?
I started writing a lot when I was a cancer patient for more like a journal experience. And I had a Caring Bridge page, which is one of these social media pages where families update their friends a lot on what's going on. And I started journaling daily and then ended up publishing a book of my experience as a patient. I had also done a lot of writing of letters to my grandfather, who is a retired professor of Christian philosophy, because during my illness, I was really struggling with my faith and having a lot of questions, as we all do when encountering children with cancer. Why? Why God? And so the book is actually called Why God? Suffering Through Cancer into Faith. And it's a collection of narratives that I exchanged with my grandfather. And his part is more philosophical, and mine is more raw and emotional and expressive of the grief that I was feeling at the time as a patient. So that was the first big time I did narrative medicine, but I found myself continue to do so as a way to cope and process things that I go through. And the most recent one, before the one we're discussing today, was a piece about fertility that was published in JCO Cancer Stories. And also, I got to do the podcast for that piece. And that was about my experience losing fertility as a patient and how that has impacted what I tell patients about fertility and how I counsel them about possible fertility loss. And the plot twist there is that I actually have 2 miracle babies that I birthed for some reason after 13 years of menopause. So now I'm not infertile, but I'm very passionate about fertility as well.
Well, I remember that essay. I also remember how impactful that was to a lot of people who read it and how helpful it was and gave a lot of people hope.
I think hope is very, very important and necessary in the realm of cancer.
My word, you have so much that you could potentially share with your patients on their journey. Or have you also been open to sharing your faith with them?
Absolutely. I am. I think that it's something I'm really cautious not to push on anyone, but whenever patients bring up faith and want to talk about that, or when they introduce that as a topic and make it clear that that's something that they are thinking about, then I'm definitely very open about that too.
Well, that must be a comfort to them.
I hope so. It's a comfort to me as well. For me, I don't know how I would do this job and lose patients and children to death if I didn't believe in something more.
It's beautifully said. In this essay, you make a close connection to your patient and his mother when you write, I imagined my own son contained in a hospital room, attached to an IV pole, vomiting from chemotherapy. I could feel the warmth of his skin against mine and the weight of his body on my chest. And as I looked back at Tristan's mother, I could only support her decision to hold her baby. What is the importance of this connection to patients, and are there any downsides? In other words, in medical school, we're often taught to keep a distance. Or there's an essay I wrote with Tim Gilligan, who's a GU oncologist and this incredible communicator, where we wonder if all the communications classes we're exposed to in medical school actually undo our natural communication and our natural connection because we figure, gee, if we have to take all these classes on communication, maybe we've got to communicate differently. What is the importance of this connection to patients? And are there any downsides? Like, should we keep a distance or not?
I don't know if we should, but I know that I can't. This is my gift and my curse. I think that taking care of someone with a sick baby, especially as a parent, is so human and so full of emotion that it's not possible for me not to feel that connection. Now, I do think there's a point at which I have to be sure that what I'm doing and what I'm expressing doesn't make it harder for them. I think it's important for them to know that I feel for them and that I am having these feelings, but I don't want it to become about me when I'm trying to help them. So I once, in one of these medical school situations, was told that the moment the family begins to comfort me might be a moment that I've known I've gone too far. And so I think that's a rule of thumb I think about is like, if I'm crying in this moment with this family, does that make them feel loved or does that make them feel like they need to worry about me? And I think most of the time it just makes them feel loved. But that's sort of the tension there. I think when it comes to me, too, I've been unable so far to put up boundaries to like protect myself emotionally. I don't know that I'm capable of that, but more importantly, I don't think that's authentic for me. And so I don't do that. I'm trying to process and grieve so that I can cope and continue to be the doctor and person that I am. But I refuse to put up emotional walls because I don't think that will serve the patient or be authentic to who I am as a person.
You bring up a couple of really important notions. And the first is authenticity, being true to ourselves. And if we're not true to ourselves, our patients will see through that and wonder if we're not being true to them. And also having our antennae up to get the pulse of the room, to see how people are reacting to what we're doing and making sure that we're serving our patients' needs more than we're serving our own needs when we're actually in the clinic room with our patients.
Definitely, I agree. And those scenarios in medical school, I remember just thinking to myself that it didn't make a lot of sense to me, and that I was lucky that this class wasn't meant for me, that I'll just do what I feel is appropriate. I always did really well in simulations, but I had no way to articulate why I knew what to do. It just, for me, I was so lucky that part came naturally, and I think it does in many of us who find medicine as a calling. But I don't know how to teach or learn that.
Well, you've seen it from the other side as well. I mean, you strike me as being a naturally empathic person and someone who's tuned into other people's emotions. You've also been there. You're more tuned in than I am, having been someone who's had cancer. I've certainly had close family members who've had cancer. My mom has lung cancer, for example. So I've been in the role of somebody in the room who's supporting somebody with cancer, but I haven't myself had cancer the way you have.
It definitely impacts my empathy. And I think that I was surprised after becoming a mother how much that also changed things for me and impacted my empathy further. Until you're a parent, you really don't know the depth and intensity of your love for a child or a person. And it was only then that I realized how heartbreaking it might be to lose a child. It's very difficult to suppress that empathy. And that's when it might not be helpful sometimes, is when I'm leaving work and thinking about someone who lost their baby and knowing that no matter how much I empathize with them, it's not going to fix it. It's been the first time in my career and maybe my life where I've had to tell myself that maybe it's okay not to have empathy in this moment. Like maybe I should turn it off for a little bit so that I can relax and enjoy my baby.
My God, it's such an interesting perspective. I think as oncologists, we have this different perspective on illness and if we're smart about it, if we're really focused and in the moment, we appreciate the aspects of life and realize how precious they can be. And that can be a lovely thing and something we pass on to our kids. I will tell you, my own children have accused me of brushing off some of their maladies with the refrain, well, it may hurt you, but it's not leukemia.
I've heard that's common with physicians' children, that it takes a lot to get a rise out of the parent.
You write at one point in the essay, at first I believed that I had no right to grieve in this way, that it was his mother's grief, Tristan's mother, not mine. I reminded myself that I was not Tristan's mother. I did not give birth to him or name him. Now, we recently published an essay about grieving called Are You Bereaved by Tricia Paul, where she also wonders whether we as oncologists have a right to grieve. What do you think? Do we?
I have to note that Trisha and I were co-fellows together in our training. So I'm happy that you mentioned her. And I need to go read that essay. I haven't read that one, so I will. It's weird to wonder if we have the right to grieve. My grandmother is a psychologist, and I remember as a child saying, like, I know I shouldn't feel this way, but about some random thing. And I remember her saying, feelings aren't should, feelings just are. So, like, maybe it doesn't matter if we should or shouldn't, but if we are grieving, we're grieving. I think in some ways it feels like I don't have the right to grieve because I have this wonderful, happy life. And this can be true of survivorship as well when I'm taking care of many children who won't get to be survivors, specifically because I care for a lot of sarcoma patients. But I often wonder, like, am I allowed to be this happy or am I allowed to not be happy because there's so much grief in their lives? So it's hard. I feel this tension often, like I'm not allowed to grieve as much as this mom, but also I better be really, really happy because I'm okay, my baby's okay. It's hard when we compare our emotions to other people's who are going through different things. But it's hard not to wonder, like, am I allowed to feel this way? Am I supposed to feel this way? For me, that's when writing is helpful. Just writing down what I feel in great detail helps me move through the feelings, I guess.
Part of the processing of it. You describe the code call for your patient vividly. You draw us as readers into your essay and into that moment, and we've all been in that moment. I remember when I was just talking to somebody about when I was in the intensive care unit, when I was a resident, and how at that time, a psychiatrist actually met with us every week to help us process what we were seeing in the intensive care unit, which was really remarkably forward thinking.
That's really great.
For how long ago I trained. How did you process it in real time and afterwards, though?
That day, even now, an aspect of me was dreading this conversation because I feel nauseated when I think back to that day, to that code. I feel like I'm going to cry. I don't feel like that in every code, but I think it was because of the parallels between the little boy and my baby. To note, my baby Houston, it's a big, bald, fat-faced baby with a binky in his mouth at all times. And Tristan was a fat, bald baby with a binky in his mouth at all times. And so even though there was a bit of an age difference, when I saw Tristan, I just thought of Houston, and I couldn't separate that. I feel often when I'm doing a lumbar puncture or running a code in real time on a patient, I can sort of dehumanize to a degree that's helpful, where I just do what needs to be done and put aside the ick feelings. But with that child in that code, I couldn't. And luckily, I didn't have to do anything but stand there and tell them when to stop or just be supportive. But I felt sick. I felt like I couldn't do anything to help. I didn't feel like a doctor in that moment. I felt like a family member of that child. And that was really difficult. I was so lucky. And I don't know how much the piece reflects this, but the other doctor who was there, the other oncologist, is a mentor of mine who's older than me and wiser than me and very experienced. And I call her my work mom lovingly. She was there and she stepped in and helped me and checked on me and made me feel like I could handle things. It would have been much worse without her there.
We're fortunate when we do have our friends and colleagues to help process this, right? Because if you're not in this field at that moment, it's hard to understand just how deeply we can also feel the pain that our patients are going through.
Absolutely.
And I do hope you'll retain that description of Houston for when you give the speech at his wedding, because I'm sure he'd appreciate that.
The big fat bald binky baby, yes. Houston is now in his mama phase, where if I'm not holding him at all times, he fake cries, mama, until I do pick him up. So it's been exhausting physically, but I must pick him up.
I have to say, it has been such a pleasure having you, Maggie Cupit-Link, join us to discuss your essay, Mother's Grief. Thank you so much for submitting your article and for joining us today.
Thank you so much for having me, and thank you for everyone for reading.
If you've enjoyed this episode, consider sharing it with a friend or colleague, or leave us a review. Your feedback and support helps us continue to have these important conversations. If you're looking for more episodes and context, follow our show on Apple, Spotify, or wherever you listen, and explore more from ASCO at asco.org/podcasts. Until next time, this has been Mikkael Sekeres for JCO Cancer Stories, The Art of Oncology.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.